Hello and welcome to Cadabam's Insights, where real conversations about mental health related issues happen. Today we have Dr. Arun V. Kumar. He's a consultant psychiatrist with more than a decade of experience in psychiatry, who had started his day early 7:30 in the morning. And he has not had lunch because there were so many number of patients that he had to see, there's so many number of families that he had to attend to, and entire day he has spent sitting in a cabin taking care of patients. That is the commitment and passion that he has in the specialty that he works. So welcome Dr. Arun for Cadabam's Insights. First thing that I would like to know is, what is it that gives you so much of energy that 6 o'clock in the evening, we are tired, but you have seen so many number of patients and attended to so many families, but you are as fresh as you are. What is it that keeps you going? And
so I think first and foremost, I think the passion towards the subject, sir. Well, I've been trained that way, you could say. My grandpa was actually, the dean of the university. So he quite strict, made sure that I'm, everything, I'm disciplined well. That's the beginning.
Fantastic. And also, the patients and the families, when we sit, we interact with them. We spend 20 minutes, 30 minutes sometimes, especially when it is a first time consultations. There are so many questions that they have. They want to understand so many things. It takes so much of time, but still we find that when they come back to us second time or subsequently, they still have a lot of questions. But you have some magic, amazing type of practice where you spend 10-15 minutes or maybe about 20 minutes with some families and the patients, and they come out very satisfied. Do you have some mantra that you have, or you have picked up something that you're able to pick up what they want, and you're very specific?
I think picking up crucial information, understanding, I give them that crucial time in the beginning, sir, to understand what their expectations are, what exactly they are presenting with. And then based on that information, I'm trying to, and their understanding of the illness, of course, I'm trying to formulate a plan where I give them adequate information, psycho-educate them about the illness per se, the kind of treatment offered. Educating the patient is very important, as well as the family, so that they are aware that the doctor knows what he is doing. That is very important, sir. That is where I think my practice runs very well.
Great. I think that would be a wonderful tip to the youngsters who have gotten into psychiatry or who wants to have a good practice in psychiatry. So let's begin with broadly. I go back to one of the family again, a mother. She was saying, Doctor, my son, he doesn't listen to me, and he gets very angry, he throws things. Give him some good medicine, nan mat kelong madi, just ensure that he listens to me. Okay. So I took a lot of time to tell her that there are no medicines to change a person's personality. When we look at these medicines, are there medicines which can make me feel happy? Are there medicines, if I am too happy, to make me come down or to be real to the reality? Or are there medicines which have an impact on my thought? Okay, what are the types of medicines which are there, which you routinely use in psychiatry?
So let me just start off with the example you gave me, sir. So there are two category of people that generally come. One that have already done quite some reading before they have come. They've tried to diagnose themselves what my son could be having or what he's going through. And some of them come, prepared that, if I go to a doctor, he's going to diagnose something and then make sure that he's going to put a medication. Now, for us, it's about making sure that we evaluate in the right way, make sure that we have a good diagnosis in place. It's not necessary that everybody needs medications. And that's a wrong perception that most of them have. So we are going to evaluate to see what severity the issue is and then appropriately decide whether there is a need for the medication or not. So there are different various conditions in psychiatry, sir. So, if you see most often, more commonly what we see is, substance use and personality disorders and, commonly, adjustment issues and mild, moderate forms of depression who come in a lot because of a lot of issues in the society and things like that. A little higher disorders which are a little bit chronic like psychosis and bipolar disorders.
When we look at recovery from any kind of psychiatric problem, how much of this psychiatric medicines important? What is their role? And is there anything else apart from medicines which are as important, if not more important, than medicines?
So most importantly, what we offer are these supportive medications, and more often than not, they are supportive medications. Just answering the question, in terms of there are some tablets, some antidepressants that can be utilized in most conditions to make sure that there's a boost in serotonin, just to make sure that some amount of happiness that we can provide so that person is able to listen or follow or get through the therapy in terms of correcting things. So we are evaluating, is that person cooperative? Is a person not cooperative? If not cooperative, why? Probably because the person is, feeling low or sad, and that is why that behavioral issues or things like that. And then, if you could go give some supportive medications like an antidepressant or a mood stabilizer, things like that, they're very supportive. Make sure it calms them down enough to listen to the psychologist, the doctor, the family, and get through the correction there.
So from a patient or a family point of view, is just medicine sufficient? I mean, I come to you and just take a pill and I'm done with it, I get well. Is that a right understanding?
No, definitely no, sir.
Okay.
There are certain conditions that warrants medications as a definitive measure, and there are certain conditions that may require medications as a supportive measure. As a definitive measure, where we know that that's a chronic illness and the medications need to be there, but either ways, both the situation, psychotherapy is a must. In definitive conditions, educating the patient, the need to be on medications, to continue the medications is very important because we see compliance issues. They go off medicines and come back, repeated admissions and this to prevent that. We want to make sure that they understand about it. Supportive medications where personality could be involved and, so you're not able to handle situations. They just make sure, the moods are a little better, calmer. And when we give you that support, they're able to, correct all the issues, solve the problems, handle situations better, get a better personality. So either ways, psychotherapy is a must.
Yeah, what you're saying is medicine is not a beginning and end of all. It is a part of the entire journey. If somebody has any kind of mental health problem, medicines, of course, are important, either as a mainstay or as a supportive, along with other forms of treatments that they need to go through. So these medicines, when we look back, I think it's not too long. 1950s is when the first psychiatric drug as such, the chlorpromazine, which was probably used in psychiatric conditions. 1950s or 60s, I think,
yes,
somewhere, yeah. So where they started using it. The last decade plus that you have been practicing, what kind of changes you have seen in the medicines, and when you are a student, what kind of medicines were available?
So I think the drugs have kind of evolved over time for sure, sir. I think the research, is such a way that, the older drugs were really good. It's not that they don't work. The problem was the side effects. The population is worried about the side effects. So I think the research was based on, trying to reduce the side effects of the medication so that the compliance to medications are good. So the efficacy and potency of these drugs remain over time, they remain the same. It's just that the side effects, I think, are coming down. So I think, earlier we would have a lot of first generation drugs, first generation antipsychotics, haloperidol, chlorpromazine, things like that. And now we have the newer second generation antipsychotics, easily tolerable, less side effects. A patient is happy, doctor is happy prescribing. So I think evolution is good, sir. Even now, after my post-graduation, we are still preparing. We are still reading because, there's a new drug in the market. We need to study that, understand that, see how it helps this thing. It's always a challenge.
Okay. So any new molecule that has come in the clinical practice, which is probably changing the prescription styles?
I think in the mood stabilizer market, we had earlier lithium and valproate and carbamazepine and oxcarbazepine, things like that, lamotrigine. I think the newer drugs like, endoxifen, I think has
I
made
hear about endoxifen of late much, yeah.
So I think that has quite made a difference, sir. Either as an independent mood stabilizer or a supportive mood stabilizer also, it's quite made a good change. I've seen good responses there. Even antipsychotics, newer ones, lurasidone, not that new, but quite newer, cariprazine and things like that have made a difference. Even antidepressants, vortioxetine.
So it's quite encouraging, and also for a patient, unfortunately nobody should have any kind of mental health issues, but if somebody has mental health problems, it's promising that there are research based newer molecules which are more effective with less side effects, which can help the individual overcome. That's very promising one to know from you. These medicines, when taken in, where do they primarily act? How do they help the individual? If you could just take us through, so all of us will have a better understanding when we are taking something, how it helps.
So it these medications primarily, of course, they work in the brain. Our psychiatric medications mostly in the brain itself. So it depends on the kind of medication that we use. And the broader category of drugs, I'll just tell you, sir, antidepressants are more commonly used. Antipsychotics are used in psychosis and bipolar disorders and things. And of course, mood stabilizers. As supportive medications, probably some benzodiazepines, the sedatives are used in all these conditions as supportive measures. Antidepressants basically, of course, works in the brain, in certain regions of the brain. Making sure that there are certain neurotransmitters that are involved, mood disorders like serotonin, norepinephrine, and dopamine. It makes sure that it regulates them so that the person is happy or sad.
You're saying neurotransmitters means these are chemicals in the brain which help in transmitting message from one cell to another cell. Probably if you could dwell a little more into the neurons and the brain cells, and plus how the messaging happens in the brain, that will be great.
So basically, the neurotransmitters are present in between two neurons basically, and then and these
are two cells.
Yes, two neurons, and that there's a transmission of signal from one neuron to another neuron, and these neurotransmitters are in between. Now, what we are trying to do is regulate this transmission. So in a bipolar disorder or mania, there's excessive dopamine in this thing. So we either make sure that it's taken out, a reuptake is there, or removed, or whatever is there, and then or in depression, it's quite less. The serotonin levels are quite less. So we make sure that the reuptake is prevented, or in a way, manufacture is more or something to make sure that we regulate those neurotransmitters in order to address the mood disorders or psychotic disorders.
So there are different kinds of these messengers. Let's call it as messengers between the two neurons which are in excess than normal in certain psychiatric conditions and less than normal in psychiatric conditions. Are there certain brain areas as well which are responsible where your medicines, you target the medicines?
Certainly, sir. Different conditions warrants different medications working at different areas.
Okay.
Now, probably if you consider mood spectrum issues, we consider the dorsolateral prefrontal cortex. That's the region.
This particular part of
left dorsolateral prefrontal cortex.
Okay.
That's responsible for the moods, the anxiety, and things like that. If you are considering, in psychosis, there's a certain region of the brain, the ventral tegmental area. That is the region that where the dopamine is produced, and that releases into certain pathways like mesocortical pathway or mesolimbic pathway. Regulating this dopamine release into these pathways is how we manage the different kinds of psychosis.
Okay.
Different kinds of psychosis have different presentations of dopamine in different pathways here. If you could only regulate this, I think the specific kind of psychosis can be regulated. And of course comes the mood stabilizers. The mood stabilizers make sure the neurotransmitters are controlled. Some, by directly acting on them, or sodium channels and things like that. But of course, the various regions of the brain are involved in various kind of disorders. We consider OCD, basal ganglia, things like that.
Okay. So when you are giving medicines, you are giving medicines to the different parts of the brain, or you are giving medicines to the chemicals? How do you choose?
Of course, it depends on the spectrum. Now, even if you consider every condition, each condition has a different spectrum of presentation, sir.
Okay.
If you see depression, it's not just a plain depression. Of course, we categorize mild, moderate, severe. But there is a melancholic kind of depression. There is a depression where there's actual sadness. In elderly, you see, they're not really saying I'm sad. You're reporting, I'm tired, I'm weak, I'm sustaagtide, ನನ್ನ ಕೈಯಲ್ಲಿ ಏನು ಆಗೋದಿಲ್ಲ. So there we choose certain kind of medications which work in those kind of areas which give that energy and motivation. Certain this thing where there's acute depression, the feeling depressed, sad, suicidal. There we use mood stabilizers and this thing to help those kind of conditions. So different presentations warrants different kind of medications, and they also work at different receptors in the brain. Dopamine receptors, D1, D2, D3, D4, D5, serotonin receptors is there. So different spectrum, different target receptors, and it works.
Okay. So I think you added one more. One is the brain areas or the connections between the brain parts of the brain which are responsible for certain functions where you target with the medicines. And second, also you mentioned about the two neurons, the two cells, the communication between them, the messengers there is the other target when you prescribe medicines, where you are giving medicines to either increase or reduce. And third, now you brought about the receptors. Receptors are primarily the cells, parts of the cells. Okay.
Yes, that's where the dopamine and the serotonin and
the messengers you're talking about. Correct. Messenger chemicals.
Yeah, so they actually that's where they connect to these receptors and work as agonists and basically against. So we are utilizing drugs also as either agonists that work similar to the functioning of these chemicals or against the functioning. So depending on the kind of symptoms or presentation, and that's how they respond well.
Okay. I think let's get into one type of category of medicines that you said most frequently used, prescribed, the antidepressants. What are these antidepressants medicines, and where does this have its impact on the brain, and how does this help individuals? So we are all so-called normal people and our moods are quite stable. Can I also take some antidepressants so that I feel more happy?
So I think that is something that the psychiatrist should decide.
Okay.
I think, because there is definitely a lot of safety involved with that, but there is also certain risks. So I don't think that the patient himself can decide whether to take or not, because a lot of history, a past, and all these things has to be decided in order to decide whether the patient can take the medications or not. So in terms of antidepressants, you were asking me, sir. So antidepressants, basically various categories of antidepressants are there. If you see SSRIs, SNRIs, TCAs, tricyclic antidepressants, MAO inhibitors, and things like that. They all depend on the region or the kind of the neurotransmitters that you want to target. So basically, in depression, you're trying to target serotonin, dopamine, norepinephrine, and
So these are chemicals they are lesser than what it should be in the brain.
In depression, sir.
Okay.
In depression, if you see most, the neurochemical theories suggest that the serotonin comes down, the norepinephrine comes down, and the dopamine also comes down. So what you're trying to do is, you want to push that serotonin levels back. You want to push that norepinephrine levels back so that that person is feeling happier, energetic, and then identify why it fell down.
Okay.
And correct that so that when we take them off the medications, they're able to sustain.
Okay. So what does these medicines do? The antidepressants, are they chemicals like you mentioned about dopamine, serotonin? You are giving dopamine and serotonin to this individual in the form of a pill?
They're not exactly the same substance,
Okay.
but they are drugs that will propagate the increase of the target substances, like target neurotransmitters like serotonin and dopamine and all these things. So when you know that particular, you want to target motivation, you want to target moods, you want to target maybe the lack of interest and lack of motivation that they present, you want to get them to start doing things, you want to boost the serotonin in a particular area, so you will choose that particular kind of antidepressant for that. Okay. And
No, I was probably in parallels comparing when somebody has diabetes. There are broadly, two types that you can, from a common man's perspective. One, I directly give insulin, which the person is lacking or less than normal that the person is going through, body is going through. Or I give medicines which stimulate production of insulin in the body. So when you are giving medicines which enhances one's mood, antidepressants, how does they help the individual?
Okay. So in terms of antidepressants, they're basically like I categorize them into SSRIs and SNRIs and things like that. So if you take a particular category, the most commonly used category, the SSRIs, selective serotonin reuptake inhibitors.
Okay.
So there is in a normal individual, the degradation, the reuptake, and the manufacture is all equal.
Okay.
They're equal, and that is why the serotonin levels are all maintained. In a person who is extremely worried and tensed, the reuptake, it's being the serotonin is being lost.
Okay.
So these drugs basically make sure that they prevent this reuptake. Make sure that the manufacture is happening and then its levels are maintained and the reuptake is prevented so that the serotonin levels build up. When they build up, whatever deficits are formed part of depression is reversed. Okay, and whatever was the reason then is corrected.
Okay. When somebody is taking antidepressants, what should they be watchful of? And is it that I take this antidepressants and I'm on antidepressants and for lifelong I have to take it? As a patient, what should they be watchful of?
Of course, most of them are worried when they come inside. They're worried that we are going to medicate them for sure, and for how long. And the first question that anybody will ask me is, "Doctor, you're starting this. Everybody tells me that I have to take this for lifelong."
Yeah.
So basically, in these kind of disorders, more often than not, sir, it is always an extension of the personality, the way they think, the way they act. the way they respond, perceive the environment, which is all molded from their childhood. Now, so what we are trying to do is see where the deficits were in terms of coping, or they couldn't handle situations and things like that, and then try and resolve them. When they are on medications, make sure that we have a certain duration. We plan a duration of treatment, make sure they get better, and hold it on until they're able to correct these personality traits. And then we take them off these medications. So what they have to be watchful about is they're all worried about the side effects.
Yes.
So in terms of side effects, they're all worried, ಡಾಕ್ಟರ್ ಇದು ತಗೊಳ್ತಿದ್ರೆ ನಾನು ಡಿಪೆಂಡೆಂಟ್ ಆಗೋಗ್ತೀನಿ ಅಂತ ಭಯ ಆಗ್ತಿದೆ, ಅದು ತಗೊಂಡಿಲ್ಲ ಅಂದ್ರೆ ನನಗೆ ನಡ್ಕ ಬಂದ್ಬಿಡುತ್ತೆ, ತಲೆ ಸುತ್ತ ಬಂದ್ಬಿಡುತ್ತೆ, and all these things. Of course there are side effects, but like I said in the beginning, these side effects these days are very, very, very minimal. They try to minimize as much as possible with research, newer drugs, newer molecules, and we are also trying to adhere to them. And these antidepressants, they really have these days very mild side effects, like there's headache and blurring or something like that. Even if they occur, it's a very small population, and we can reverse them or alter the dosages or change the medication and things like that, and it should be fine, sir.
I'm stressed, so I need antidepressants. Okay, I'm taking antidepressants because I am stressed. Is stress and antidepressant, the treatment, or is that how things are practiced?
Stress is not exactly the symptom. Stress is that person's inability to handle a problem.
Yes.
Stress is very, very subjective. So stress for one is not stress for another, sir.
Yes.
So that clearly, that is where the problem arises. It's clearly the personality of the person that could be an issue here. So what we are trying to do is, because of stress, there are emotional disturbances and moods are bad, and that person is not able to solve the stress. So we're giving supportive care so that he's happy enough to find a solution for it, and change his personality as well in order to address the newer problems that he may face. You have to keep him prepared. You want to make sure that this stress is no longer stress, and he's prepared for the future.
Because I do see, when I interact with especially the techie population, we are stressed out, so I need some antidepressants, So that's where the question comes. From antidepressants, let's move to the anxiety part of it. You said anti-anxiety medication or anxiolytics. What are these medicines, and how does these medicines help the individual when they are going through some anxiety episodes?
Again, anxiety is classified into various spectrums, sir. Under anxiety comes even phobias that are chronic onset right from childhood. Generalized anxiety, they're anxious by nature, and off late developed into anxiety disorder and things like that. So what we are doing here is, of course, giving supportive care. If at all it's an acute presentation, we do try and avoid antidepressants for corrective measures. Offer supportive care till they're able to solve an issue like anxiolytics. They work on the GABAergic receptor, make sure that the anxiety levels come down, and keep him calm enough to solve the problem. If at all the severity grows, then there may be a requirement of a supportive antidepressant at some times.
So even when somebody is going through anxiety episodes, the treatment options or the medicines that you prescribe are antidepressants?
Yes.
Or are they combinations of something?
They're mostly antidepressants, sir, because the spectrum is almost the same. The depression and anxiety is the same. The region of the brain is the same. It's just that the presentation is different.
Okay, understand.
So again, in anxiety, it's again a low confidence and a low self-esteem that is the root issue for anxiety to develop. So you want to produce a serotonin to confidence to build, and automatically the anxiety disappears. So if it's a very acute presentation, you don't need to really start. It also depends on the kind of disorders. But if at all it's a chronic one, and we need to provide enough support for him so that he gets through a good amount of psychotherapy, supportive antidepressants are used for a short duration based on the kind of disorders.
Sure. With antidepressants being taken, are there any do's and don'ts? Like with respect to food, with respect to sleep patterns, exercises, any do's and don'ts that is there?
Certainly, sir. Most often, in our country, what I see most often is utilizing some substances that are available to cope up with, anxiety and depression. So substances, alcohol and things like that. The first and foremost I am going to indicate and tell them is to avoid any kind of substances like alcohol or nicotine, that's smoking and things like that. The best lifestyle change. Other aspects, of course, other lifestyle changes are very, very, very important. Having a good sleep-wake cycle, having a good diet, having a good social circle. All of this definitely, is very much required in order to get this correction done. But this is, of course, regulated by a psychologist based on the kind of a disorder they are having.
Okay. But there are no contraindications as such that if you are on antidepressants, you should avoid these kind of foods, or you can take these kind of foods. Any dietary restrictions?
No dietary restrictions. I think, antidepressants, they go well with any kind of food. No real issues there. The only, like I said, the substances should be avoided. And they, if they're on any other kind of medications or any other medical issues, then we are going to consider the usage of these antidepressants, because they could have some drug-to-drug interactions with other medications and things like that. But I think foods are avoided. What we also recommend is to reduce sugars a little bit, because during depression and anxiety, people take in huge amounts of sugars. That's a problem. I think the antidepressants can do a good job and reduce. People have binge eating and weight gain and things like that. So that's something that they should be looking for.
Okay. Please help us understand what are these antipsychotics and what are the different types of antipsychotics that is available, and where do you use them?
So antipsychotics are classified into the first generation and the second generation. So of course, the first generation, like we discussed in the beginning, 1950s, chlorpromazine came out, then haloperidol came out, and things like that. Right, even now, haloperidol is one of our backup medications. If none of the second generation works, we come back to haloperidol. But the problem with them, we don't use them as a first line because of the side effect profile.
Not so much of chlorpromazine is used, that's what I find. But still, haloperidol, nobody has left haloperidol, but
it always saves the day. The haloperidol always saves the day, sir. It's always the psychiatrist's backup. Yeah. So
and works wonderfully.
Wonderfully, sir. Most of this treatment resistant cases, things like that, haloperidol does that kind of magic I've seen.
Yes, I agree with you. I agree with you.
But we still go on to the safer ones first. So we go on to the second generation first. Anyone presents with any kind of this psychotic spectrum, or if you talk about mood spectrum, they could be having bipolar disorders in a manic state. The dopamine levels are very high, or depression, where long-term depression has led to psychotic symptoms, depression with psychotic symptoms. So we use it primarily with psychotic presentations or aggression, anger. We use it even in children also sometimes to control the behaviors. We use it in people with dementia also to, help them regulate the behaviors. So second generation antipsychotics more preferred these days, and very good options in the second generation.
Can we just little elaborate on the psychotic? What do we mean by, because in the common language, when people are saying, oh, this fellow is a psychotic fellow, means he is unrealistic or irrational, or somebody who's aggressive also is a psychotic. So from a technical point of view, what is it that constitutes this psychotic behavior or this psychosis?
So in psychosis, of course, the aspects they present is totally unrealistic. Any common man will be able to identify that there's something wrong about this individual. So for us, it is primarily a presentation of certain spectrum of issues. First and foremost, there's some presentations like hallucinations. Hallucinations, they could be auditory, visual hallucinations, tactile hallucinations, olfactory and things like that, where they're able to see or taste or hear things that are not heard by others, and that and they react to it. So over time, their reality is lost. That is one of the spectrum that is there. The others are more commonly the delusions. Delusions are, we are all, all of us are careful about a lot of things. We say, we should be careful, people can take away something, but they are more than careful. They're too extra cautious. They feel that the people are trying to harm them and people are trying to hurt them and things like that. We categorize them as delusions of persecution and delusions of reference. Sometimes there could be other delusions of delusions of grandiosity. Feel that I am the Maharaja, I am the king,
God.
I'm God, things like that. So I think these are the commonest psychotic symptoms. There are other psychotic symptoms that are also there, like something like catatonia. These we've seen this in the movies. People are stuck like statues and things like that. That is also a higher form of psychosis.
Is it fair to understand what you said, that the thinking, the thought process that this individual has, which is at the surface level, which is the problem that we are identifying, that he is thinking something which is not real, while your treatment is not directly at that particular thought process. It is the root cause, from where is this abnormal thought, unrealistic thought that is coming in, and you are trying to target that, and that target is the chemicals, the neurotransmitters, or the messages between the cells that you spoke about. So what are those messengers, or what are those areas of the brain that these antipsychotics act upon?
Like we had the classification of antidepressants, even antipsychotics have their own classifications. So in terms of antipsychotics, like I said, there is the first generation and the second generation antipsychotics that we're talking about, and each of them act in different ways.
Okay.
Even if you consider the second generation, there are a lot of antipsychotics.
Let's focus on the first generation. Try and understand what do they do.
So first generation as such is also called as the typical antipsychotics.
Okay.
And they primarily only handle the dopaminergic receptors. They work as antagonists. Antagonists in the sense they block those receptors so that dopamine, just block it so that the dopamine that is excess does not act. And then that in turn controls the psychotic symptoms.
Okay.
When it comes down to the the second generation, we are targeting both dopamine and to some extent serotonergic also.
Okay.
They are more selective towards serotonergic receptors, hence the side effects are lesser.
Okay. As we know, in brain, the dopaminergic receptors, that is, dopamine it's a neurotransmitter, it's a messenger between the cells, and cells which respond to this dopamine is what we are calling it as dopaminergic receptors. And these dopaminergic receptors, or these cells which respond to this chemical dopamine, are there throughout the brain, or they are there in many cells, or majority of the cells of the brain. But are there specific areas or the pathways or the circuits that you are targeting?
Yes, sir, certainly. When it comes down to dopamine, the area that is targeted is generally with the VTA area, the ventral tegmental area. That is where the research says this is where the dopamine is in excess.
Okay. In a person having psychosis.
In a person having psychosis. And the kind of presentation that they will have is based on how the pathways originate from there. There are certain things, the ventral tegmental area to the nucleus accumbens in the brain. Okay, this is called as a mesolimbic pathway. So this is the commonest pathway where most of the psychotic symptoms originate from.
Okay.
So excess dopamine in this area, VTA, is released and then acts on this nucleus accumbens. It's also called as the reward pathway also, where they feel that feel good factor. Substances also surge the dopamine, alcohol and stimulants and things like that. But what we are targeting is exactly that area to bring down the dopamine so that the psychotic symptoms come down. Other areas also are there, but this is the core area.
So you mentioned about one being the dopamine and another being the serotonin. The newer generation or the second generation antipsychotics having much more affinity or having its impact on the serotonin, though they have their own effect on the dopamine also. Are there any other chemicals in the brain which are responsible for psychosis and these antipsychotics have an impact or effect on?
Correct, sir. Certain neurochemical theories suggest there are other neurotransmitters like glutamate. Glutamate is one which also regulates, causes psychosis. But more often than that, we are not targeting that area. We are targeting the dopamine only, even though there's a glutamate.
So when somebody is on this antipsychotics, as you rightly pointed out, the biggest question is about the side effects and how long I should take. So what do you say? What do you suggest these patients?
So in terms of psychoeducating them is very, very important here, sir. So in terms of what the side effects they are going to expect, because I don't want them to go back and suddenly say out of the blue, this is come back and doctor, and they come back every time. So we do educate them in terms of common and rare side effects. Common side effects, mostly, some things like, dry mouth and things like that most of the antipsychotics will have. And sometimes some very specific antipsychotics could some kind of rare side effects. We also educate them. But based on the presentation, we could definitely change the antipsychotics or lower the doses or adjust them.
Okay. So before somebody starts taking this antipsychotic medication, are there any investigations or checks that we have to go through, or are there any regular checks that individual on antipsychotic should go through?
We certainly do a general checkup. We want to know the renal functions, the liver functions, because these drugs, the kidney functions and this thing, because they are all eliminated through the kidney and the liver and all these things. So these basic investigations are a must. Heart functions, ECG is a must. Okay. The thyroid functioning is a must, because either the thyroid itself could, make sure that the medicines don't work fully effective.
Okay.
So make sure that, that is not impaired. We correct them parallelly. And functioning of liver, all these things regulates the dosages that we give and the kind of medication that we give. So, we do investigate for that. And even the ECG is certainly very helpful.
So before they start this antipsychotics, you suggested that, kidney functions, heart function, liver function, thyroid, you evaluate, and once they're on these medicines, are there any specific requirements of how frequently they should get these investigations, they get these checkups done? This I say because I quite often, I come across people who have met the psychiatrist some 2-3 years back, and doctor, they gave medicine. With this particular medicine the doctor gave, he became all right. And last 3 years we are taking this medicine. Okay. Because he was doing well, I didn't go and meet any doctor. Why should I meet, I'm doing well with this one tablet. Why should I go? So how safe is that, and at what intervals do you recommend these people undergo some investigations and also meet the psychiatrist?
So, initiating these medications, we certainly follow a certain protocol. It all depends on the sex of the individual, the age of the individual and things like that. Start off with basic doses, monitor the response to those doses, call them back for frequent follow-ups. That's a must, every 2 weeks or 3 weeks, just to make sure there's no side effects and they're responding well. And then appropriately adjust the doses to the required levels. And then once they have a good response, come back for regular follow-ups at intervals like 1 month or 2 months until the planned duration of treatment. The problem that we face is once the patient gets confidence in the medications, the patient tends to forget the doctor. And then the patient only remembers the doctor when there are side effects, long-term side effects that may come. That is why we need to monitor on a regular basis and regulate how long it has to be taken.
How frequently you think somebody who is on antipsychotic medication should get the investigations done and should meet the psychiatrist?
So generally we get these investigations done, once in 3 months or 4 months, just to make sure that the functioning, it's not that the medications are going to cause any deterioration.
Okay.
It's to make sure that other associated medical conditions is not causing any deterioration, and then we can still continue these medications. That is the reason we most often investigate the liver functions and renal functions. There are certain medications that, certain antipsychotics that needs additional evaluation, frequent evaluation, something like this clozapine. It's a little rarely used drug in the sense it's used in treatment-resistant cases that warrants a little more of higher investigations and ECG and cardiac status and things like that. But it's very drug-specific.
Okay. Because I have seen a lady who was started on with clozapine, okay, and about 75 milligrams of clozapine, and the patient felt better, and patient's husband, he also felt that my wife is some kind of a delusional disorder, probably schizophrenia spectrum, you can say. So because both of them they felt better, okay, they had no idea that they need to monitor their blood counts at regular intervals, and this clozapine has an impact on their blood counts, and it's about 2.5 years. Fortunately, the lady did not have any kind of problems, but potentially it could have damaged her system, she might have ended up in emergency department or some kind of a major medical issue, but unfortunately the understanding, or some of them, they do not have. So when they are on antipsychotics again, can they lead a normal life? Can they drive? Can they get married? Can they have children?
So I think that is exactly why we are even giving antipsychotics,
Okay.
Because if you consider the disorder per se, the amount of disability these disorders cause is much, much higher. We are trying to improve the quality of life by giving these medications and making sure that at the expense of least side effects. We want to make sure that the side effects are as least as possible, or they don't have side effects. Of course, most don't have, but some do develop some side effects. We are trying to outweigh the benefits in terms of the risks and make sure that we give them something that is safe for them for the duration that we intend.
Okay. So it's quite safe to drive. It's they can get married. You're saying you want them to do all of it. That is why you're giving medicine.
Yes, definitely, sir. I want them to come back to as normal state as possible, as any other individual. Make sure that the functionality is as good as any other normal individual. They certainly can do. If any particular medication warrants certain indications, avoiding certain practices or certain routines or things like this, we do indicate, but most often none of them, are as risky as we all think.
Can lead a normal life while
yes.
taking antipsychotics.
Yes. People forget. Everybody is worried about side effects. Nobody is really worried about the disorder per se. So, doctor, dayavitu vasi ಮಾಡಿ ಕೊಟ್ಬಿಡಿ, but later dayavitu tablet ತೆಗೆದುಬಿಡಿ. Symptoms. So they forget the intensity of problem that they had when the medicines were not.
Correct. And how safe it is when somebody is on antipsychotics to take alcohol or smoke cigarettes. Smoking cigarettes with people with psychosis is so common. So how safe are they?
Certainly not safe, sir, because if you consider alcohol, is going to surge that dopamine. You're trying to bring down the dopamine with antipsychotics, and you're taking alcohol that aggravate. Doctor, antipsychotics ನಾನು ಇಷ್ಟು ತಗೋತಿದ್ದೀನಿ, ಇದು ವಾಯ್ಸಸ್ ಕಡಿಮೆ ಆಗ್ತಿಲ್ಲ. What are you doing? Frequently alcohol ಕುಡಿತಿದ್ದೀನಿ. How can they work? Unlikely that they are going to work as effective as supposed to be when they are taking something that's contradicting the use of antipsychotics. So alcohol should be avoided, and nicotine basically used to handle that anxiety associated with these symptoms. So they are all anxious about these symptoms. So in order to address that, they're taking these nicotine and things like that.
But is it okay to take few cigarettes, smoke few cigarettes while the person is on antipsychotics? Because that's very common. I find, I've seen people, one gentleman, he himself was a doctor. When he developed psychosis, schizophrenia, people noticed that he has got schizophrenia because he was never a smoker. He started smoking almost 70 to 80 cigarettes a day. Okay. And when he was started with antipsychotics and things got better with him, he was saying that was acting like antipsychotic to me. It was helping me.
So if you see, sir, this psychosis and mood are interconnected. Psychotic symptoms flare up when the moods are bad or a person is anxious. So he's not directly trying to address that, he's trying to indirectly address it by taking nicotine, trying to cover up the anxiety. So when the anxiety comes down, then the psychosis a little bit, but it's not the right measure. It's not the right corrective measure. As a psychiatrist, I am going to make sure that, he should be refrain from all these substances. But, if he's using it, it's not going to cause an issue. The only problem is the efficacy of the drug will come down because the drug will get metabolized quickly.
The efficacy of antipsychotics will come down if the person is taking
any other substance.
Smoking, if he is smoking along with that.
Because the drug will be metabolized quickly.
And coming to the last part of our, the medicines in psychiatry, the mood stabilizers that, you spoke about. What are these mood stabilizers? What do you mean by stabilizing the mood, and what do they do on the brain?
So mood stabilizers, as the name suggests, is to make sure that the person is calm. Make sure that any disruptions in emotions that are occurring in the brain is settled. So in mood disorders, basically it's either depression or in mania. You want to make sure that these fluctuations are not occurring. So these are offered to make sure that these neurotransmitters are regulated within limits. Okay. And then either the highs are under control or the lows are prevented. So these more often are used in people with a little chronic issues, recurrent depressive disorders and chronic bipolar disorders. They make sure that these further episodes are prevented. They can also be used and maybe in people with personality issues, because there also emotional fluctuation is seen, a lot of emotional fluctuation. There also mood stabilizers are very, very helpful.
So what do these mood stabilizers do on the brain? Where do they act? When it came to the antidepressants, you spoke about, mood enhancing chemicals of the brain, and when you spoke about antipsychotic medication, you focused on the dopamine, serotonin part of it. So when you're talking about mood stabilizers, which chemical of the brain is it targeting?
It depends. They're of course they're all different mood stabilizers. Sir. You're talking about lithium and valproate and carbazepine and things like that. Basically, lithium. The science behind it is not much identified, but known to work on the sodium channels and neurotransmitters per se. They make sure that they are regulated within charge. The specific this thing at the moment is not that concrete. No one really knows how much it works. If you talk about so valproic acid and things like that, that work on this GABA inhibitory GABA system, and that also regulates the neurotransmitters in the brain and hence controls the fluctuations in the mood.
Okay. So when people are on this mood stabilizers, again, what are the do's and don'ts that you recommend?
The mood stabilizers per se, it comes with a little bit of more side effects than the other ones. So now monitoring is very important. The kind of the mood stabilizer that we use, one is the specific monitoring of system. For example, if you're using lithium, you want to monitor the renal for the kidney functions regularly. So you want to maintain a good health in terms of the renal functioning. So we try and avoid any of these substances or anything that can hamper the kidneys. You want to make sure they're regulated. Make sure that the drugs also, drugs that can interact with lithium is prevented. That can worsen the functioning of kidneys is prevented, and things like that. If you're working with sodium valproate, you want to monitor the liver functions, and then make sure that there is no alcohol around it, because with alcohol it's going to deteriorate the liver functions per se, and make sure that the lifestyle is good enough to support it. Dietary changes, certainly, with all these medications there's going to be a little more hunger, there's a probability of a weight gain, so you want to regulate the lifestyle also there.
Okay. And with this mood stabilizers that these people are on, of course the substances you did mention, the alcohol and smoking, to be avoided. Are there any dietary restrictions when they are on these mood stabilizers?
Nothing specific, sir. Again, coming down very like antidepressants, nothing very specific. But we are on, I do say, reduce the carbohydrates during these when you're on the mood stabilizers, because they all tend to put a little bit of weight gain. There's always a little bit of binge eating that can be there. So, could avoid rice and things like that to put on weight. Make sure there's a lot of salads in your food and diet, and make sure, good lifestyle, routine, activities, workout.
Okay. Can psychiatric medications change personality of an individual?
Psychiatric medications, I have seen a lot of families come and say, like we started the conversation, Doctor, one tablet kodi ange avaru nan kelodu angu follow ಮಾಡ್ಕೋಬೇಕು. These medications are not going to change anybody's personality, sir, but they're going to help change the personality of a person. The patient should be cooperative enough to understand where the deficits in my personality are and bring about a change. And mood stabilizers offer that platform to make sure that he's calm enough, his moods are good enough, there's reduced irritability, anger, impulsivity, and all these things. And he gives them more time to understand what the problem is and resolve it. So they are supportive measures.
And psychiatric medications, all psychiatric medications have a lot of side effects. What do you say?
They have side effects, sir. But certainly, it is our duty to make sure that they face as least side effects as possible, or no side effects also. And even if you see that the probability is not that high, it's a small 5% or 10% and things like that, we certainly can't predict who can develop what kind of a side effect. So this regular monitoring is very, very important.
Once a person is on psychiatric medication, they are on it for life. How true or false is it?
It depends on the condition, sir. It depends on the condition. We consider a lot of facts, a lot of things in terms of the decision that we make. I don't think any books can tell us what is the duration, because we need to custom make or tailor make this treatment for an individual. Every individual is different. There's a family history, there's a past personality to it, there's active stressors to it. So the duration of treatment depends on, whether we have addressed these issues, is he able to handle the situation, whether his personality right now is better. So because every disorder in psychiatry is always, I believe, is triggered by the personality. His inability to handle a problem causes stress that triggers an episode of some, a psychotic episode or a bipolar episode, things like that. So I would suggest the duration and the extent of medications depends a lot of factors. So we do
That's
our
not
best.
True.
That's not. It's not. We will do our best to make sure we minimize the duration, the dosing, and to minimize as much as possible.
Once I start taking psychiatric medication, I become dependent on it. Is it true?
Sir, I think we are talking about, when you're talking about psychiatric medications, they're all classified into antidepressants, mood stabilizers, and antipsychotics. Dependency is seen in certain medications which give immediate relief, cross-sectional relief. They're not curing the problem. Like, we're talking about sleeping pills or sedation. They are very regulated medications. Those are the pills that can get addictive, but we regulate them and make sure they are off it before they get addicted. But the other medications which give relief over time don't get addicted. That's something that corrects a person over a period of time. There's no addiction about it. If we solve the problem, there is no need to continue these medications. So addiction is only down to cross-sectional medications that give cross-sectional relief.
And in psychiatry, one tablet will not help me. I need to take multiple pills. How true or false is that?
So for us, choosing the certain medications which can work on in multiple ways is very important, because compliance to treatment is very important in the patient, and they're all looking at doctor nalak kodbedi, aid kodbedi, one man kodi. So we are trying to choose something that has multiple properties. There are certain antipsychotics with a little bit of a mood stabilizer property. There are some mood stabilizers with an antidepressant property. So we are trying to minimize the number of medications by choosing something that is compliant, that adheres to all the other issues as well.
True. I mean, something which reminds me is a nice statement at Stephen Stahl's psychopharmacology book. Brain itself is a polypharmacy, and there is, as psychiatrists, brain prefers a polypharmacy, multiple ways of tackling a particular problem. Even while studying psychiatry or the different subjects of psychiatry, this psychopharmacology is it's considered to be a very dry subject. Even I think students, when we interact with them or when we talk to them, they also say, oh, it's a very dry subject like anatomy. But that is the most important aspect when you are sitting as a clinician, and that's the only arm or armamarium, it is one of the tools that you have to fight the illness. The conversation for the last minutes that we have had, 40-50 minutes that we have had, you have kind of simplified the most complicated aspect of psychiatric practice, the prescription of medicines and what are the different types of these medicines, where do they have an impact on the brain, and what are the do's and don'ts. Of course, when people are having problem, they should go and consult the psychiatrist and follow whatever the psychiatrists are saying. But the positive thing is there are newer generation molecules, medicines that has come in the clinical practice, and they are with least side effects and having potential effects on the problems that the individuals are going through, which is a very, very encouraging one. So thank you so much for making time and being here, and I will certainly come back to you for one more session on one more important or an interesting topic in psychiatry. Thank you so much, Dr. Arun, for being with us on this Cadabam's Insights.
Thank you so much for having me here, sir. I'm a little bit of a person who tries to educate as much as possible, so I will utilize all platforms to make sure that I educate as many as possible.
Thank you so much. Thank you.